Pete had asked me to talk on this tape to try to explain some of the pain I have had for the past 6 years. It started, excuse me, in 1983 with just a dull ache on my right side of the jaw, radiating up into my right ear. And I had my teeth x-rayed here, and they found no problem, and it was just kind of intermittent pain, so I just didn't pursue it any farther until in December I really got a toothache down on this right lower jaw. So I went to the dentist, and he did find that I had an abscessed tooth, and he tried to do a root canal. I still continued to have the pain, and as I say, radiating up into my right ear. So he sent me to a root canal specialist here in Ames, and the root canal specialist said that a root canal would not help me at all, that I needed to have that tooth pulled. So I went back to my hometown dentist, and he did pull the tooth, and I continued to have pain. That went on for a good month to 6 weeks, and I thought maybe it was the tooth right beside it, and I'm still talking down on my right lower jaw. And he didn't want to pull another one, but at my request, he did pull the tooth beside it. The pain was still there, and after about a month's time, we talked about a bridge, and he did put a nickel-plated bridge in. And that was worse than ever. It was a squeezing pain then, and I could taste the metal from the bridge. So with that, I decided to come over to Ames to another doctor. And I just picked one at random here in Ames, and he put in a gold-plated bridge. And I didn't have the taste, but I still had the pain. And it was bad. I didn't want to go to work, excuse me, and yet I knew I had to. I work part-time as a nurse, and I do a lot of talking and teaching, and so with that I decided I would, this dentist here that put the second bridge in sent me to a periodontist, maybe thinking it was a gum disease. And that dentist said that that wasn't my problem either, and recommended I go to Iowa City, to the College of Dentistry there. So with that, my first appliance, my first appliance was made. This did relieve the pain, but however, I couldn't talk with it. I don't know if you can see, it's so thick. I would put it in now for you, but it won't fit because of the changing of my bite from my other appliances. But this was so thick that I couldn't wear it to work and talk with it. So again, I was discouraged. Meanwhile, I was put on maybe 3 or 4 different drugs before I had gone over there. One of the ones they started out with here, I did go to a couple oral surgeons here too, and they put me on the Dilantin and Synalgos. It was the first 2 that they tried, and that didn't touch the pain at all. Then when I went to a neurologist here in Ames, he tried the Tegretol, which is supposed to be a drug of choice for this type of pain, and that didn't help either. Which reminds me, I want to tell you now that if you ever take Tegretol, that will raise your ANA level in your blood, in your lab work. And when your ANA is raised, then they think you have lupus. So just keep that in mind, that that's what causes your ANA to be elevated. Anyway, back to Iowa City then. When I complained about this thick appliance and not being able to talk with it, he made me this little appliance. I could talk with it better, but it kept chipping off. These are just made out of plastic, and it kept chipping off on both ends. So this really wasn't serviceable, and I wasn't satisfied with it either. So I came back, and meanwhile I was going to have my teeth cleaned at the periodontist every 6 months. And so he suggested that I have this top appliance made, which was much better than the ones I had in Iowa City. And I could talk somewhat. I couldn't pronounce my S's, and there was another, it was something else I couldn't pronounce very well. But I did get relief from pain with this. And when he told me he was leaving town, I told him he better make me another one, which he did. He did make, and these are both the top appliances that you wear on the top of your mouth. However, the first one always fit better than the second one, and he told me that no two would fit the same. I was very thankful for those two appliances because I did get some relief. I still had the pain, and it still radiated up to my right ear. I went to an ear specialist too before I got these appliances, and he thought it was pain radiating from my teeth. So I knew it wasn't an ear problem. After that then, I decided I still wasn't happy with the appliances, and I still wasn't getting complete pain relief, so I was recommended to an anesthesiologist in Des Moines that he had given some nerve blocks in the lower jaw, and it helped some people. So I did, he attempted 2 different nerve blocks, but they didn't make one bit of difference. It didn't help at all. So with that then, I did go to Rochester to Mayo Clinic and saw a neurosurgeon there, an oral surgeon, and a few other doctors. With that, they did find that I did have a little malformation in my right TMJ joint, but they did not think that that had any factor in the pain that I was still having in this jaw going up to my ear. And they told me I had to go home and live with what I had. So you know how I felt when I was coming home from Rochester. However, meanwhile, I was still, different dentists and doctors prescribed a number of different drugs, from tranquilizers to painkillers, and none of those helped the jaw pain either. So my daughter was recommended to come to Dr. Reedhead here to have her teeth cleaned because she was knew her names and wanted a dentist here. And she told Dr. Reedhead's oral hygienist about my condition, and she recommended that I come to see Dr. Reedhead. So that's how I met Dr. Reedhead. But I still didn't have too much hope, because he too thought I should still try to wear an appliance. However, he thought that an appliance that I would wear on the bottom instead of the top, with a wire in the front so that I could talk better, would be more beneficial to me. So he started out with this one, which is plastic on the sides with the wire in the middle and no plastic in the front. So therefore, when I talk, my tongue can, come around here better, and I think I can pronounce my words a little better. And by this time, I think I did accept that I would probably have to wear an appliance. Where before I thought maybe a nerve block or a deadening of this nerve somehow would take away my pain, but by then I accepted that this would probably be my best pain relief. I also did have some teeth build up. They added on maybe a fraction of an inch so that my teeth would come together better. But that didn't help that much either. So I wore this one that Dr. Rita had made for me for approximately 9 months or a year, and it too kind of, the plastic would break off of the edges. So he told me then that he could make a metal one, which I was very happy about. And so I'll show you this metal one, which he made then for me, and I've been wearing for the past, I think I got it a year ago in January, so I've had it maybe about 14 to 16 months. I'm very grateful with it because, like the plastic, it doesn't chip on the edges. I can eat with it if I have to. However, I usually take it out when I eat because the food packs around it. But I feel that I'm very, very, grateful to have this, because when I have it in, I have no pain at all. Now, just since I've had it out, the pain is there already, just in a matter of a couple minutes. The pain comes right back. It's along that whole bottom jaw, and it just goes right up into my ear. But it goes away just as fast as when I put it in. The pain is gone again. I understand it's a change of bite. If I understand Dr. Rita right, that is what's taken my pain away. So other than that, I guess that's all I have to tell you. I would have been happy if somebody would have told me this 5 or 6 years ago. I am so grateful that this appliance does work for me, and I hope that it would work for anyone else that has any symptoms that I do.
We won't even look at it. And I'm gonna have to, I gotta look back at your chart here for a minute, see where we, December 1987. Okay.
Now, I'd been doctoring it quite a while before that, because I went to Bonfala.
Uh-huh.
I'm not supposed to mention names in it.
That's okay, we can edit, that's not a problem. So let's just start this way. Phyllis, I saw you in December of 1987, at which time we evaluated you for temporomandibular disorder. Can you tell us a little bit about how things started, what symptoms you first experienced, and about the approximate date of when that happened?
It probably started in about 86, give or take. It'd been going on about a year before I came to you with it. And it started out with just the numbness, and then it got to where my speech was getting slurred.
Mm-hmm.
And then I thought, well, maybe it's from migraine headaches, which I have. And
How long have you had migraine headaches?
since I've been old enough to remember.
Do you have typical migraine headaches, the kind where you get what we call prodromal syndrome? Your eyes will change, your vision will change, you get spots.
And I throw up.
Okay.
I get violently sick, and I usually have to go get a shot. And I thought that might be, maybe if this was related to the migraine headaches.
Sure.
So then the doctor said, well, he wanted to do a CAT scan. Well, he just did it there at Story County, and he thought first he told me I had brain lesions.
Mm-hmm.
And I thought, no, I'm not going to buy this. I don't have this. So then I switched doctors, and it really baffled him. He didn't know what I had either. So that's when he sent me to Iowa City, and they thought I had MS, and I had all these umpteen tests ran, and nothing showed up. So it really confused them. So then I was going to a chiropractor to get my neck snapped, so to help prevent headaches. And I was
Did that help your headaches to have your neck adjusted?
Mm-hmm.
Okay.
Yeah. And so I was telling about this numbness that I had off and on in my face, but it had mostly been on. I was having it more often. So he squeezed in my jaw,
Mm-hmm.
and he said, you have TMJ. So he said, I know this real good doctor. I said, who's that? And he said, Dr. Rita. I said, that's who I go to.
Okay. How extensive was the numbness on your face? Can you show me where?
It was it started, well, it started right in here first, and then it kind of got over more in my mouth, and it got on my tongue. And then it just kind of generated up the side of my face, and then it got in my neck, and then down my arm, and then it went down my side.
So how far down your side did it
I
go?
would go put it on my whole leg, whole left side.
Your whole leg, you had a fair amount of numbness in your left leg?
That's why, that was one of the suspicions he thought of MS.
Right.
That's when he really had me checked, when it was going down my leg.
Yeah. And you were concerned that you might have had
Have
a stroke.
Right,
Okay.
yeah.
You did not experience any pain, particularly
No.
at any time in your
No.
face?
No.
Okay.
Well, my jaw, every once in a while my jaw would pop out, and I thought, well, maybe that's what it is.
Okay.
You know, that this thing was coming out and it was pinching the nerve, and then, you know. But it didn't do it, my jaw never came out that often. And when I could feel it starting to come out, I just go pop like this.
And you pop it back
Back in,
in place?
yeah.
Okay. You're missing several upper teeth, particularly on your top right side. How long ago do you remember were those removed?
I don't know. I just
Quite a
honestly
while-
don't know.
quite a while ago.
Oh, yeah, it's been a long time ago.
Okay.
They've been gone quite a while.
Okay. And we're reviewing history that's 3 years old now, so that this is a little difficult to maybe to remember. But you indicated on a form at that time that you evidently had quite a few problems with your ears. You had marked that you had ringing in your ears and stuffiness in your ears. Do you remember anything about that? You indicated you had a hearing loss.
I think the hearing loss part, when I first really noticed that was when I was taking swimming lessons and diving in the deep water.
Okay.
That's when I really noticed starting having the hearing loss. The ringing in my ears.
Yeah.
Again, headaches. You know.
Okay. That you would attribute that to
Yeah.
to headaches.
Mhm.
Okay. Let me just review here a little bit more. You still you did a lot of talking on the telephone at that time. You still work at SCS, and I mean you worked at SCS then?
Yes,
Okay.
yes, right.
And did you find that at that time talking on the phone aggravated your problem?
I usually had to use the right side of my ear. Use my right side of my ear, I'm sorry. My right ear, other than my left ear.
Was that you couldn't feel or
Well,
couldn't hear?
yeah,
or?
right. It was hard to really judge, and then it was hard for voices, I guess, to distinguish. And to distinguish what they were saying, because what I do on my job, you know, I really can't afford to have any mess-ups, you know,
Mhm.
as far as messages or anything, so.
Right.
It was me, yeah, I was afraid of my left side.
Now, when you went to University of Iowa medical school and had the evaluation done down there, so their primary concern was that you might have MS,
Correct.
and they put you through a series of tests to
Correct.
ascertain that.
Mhm.
Did they, when that came out negative, did they have any other thoughts, or did they pursue any other avenues with you?
No, they didn't know. They just didn't know where to go from there, unless I wanted to go back for more extensive tests. And the one test that I wouldn't let them do to check for nerve damage on the left side was they put some kind of a shock around my left hand to shock to see. I don't know how they do it,
Mm-hmm.
but it was to shock the left side of my body basically to see how much nerve damage was done. And I said, no, you're not hitting me with any currents.
Uh-huh.
You know, and I never did let them do it.
Okay.
And so I really don't know how much, nerve damage I have.
Yeah.
So I said, mm-mm.
Do you feel you have nerve damage now? Do you have any residual kinds of symptoms?
No, I don't think so. I don't feel there's any nerve damage.
Okay. No hearing problems that you're experiencing
No.
now, and you don't, we made an appliance for you, and how long do you remember did it take for the symptoms that you experienced to go away?
Well, probably took probably 2 weeks to say that I don't have that anymore.
Okay.
you know, at the
Yeah.
time.
I'm not remembering, and it's been a long
Yeah,
time.
you're right.
Which is good. We don't want to remember those things. Um, and then after we had you in appliance for a while, we made a removable partial denture for you,
Right.
which you wore, and as long as you wore that,
No problem.
you were okay.
Right.
But if you would take it out,
It would probably, if I left it out over a week, I would notice some numbness.
return it.
Mhm.
Okay. Wouldn't, but it didn't come back real rapidly,
No, it
nor
was a
as
gradual.
extensive
Right.
as you had before. And
Right.
so then at that time, you put the partial back in.
Right.
And the symptoms, would they go away fairly quickly?
Yeah, within a couple of days,
Okay.
it'll be done.
Okay. All right. I think. So you saw two different physicians then before you went to Iowa City.
Right.
And then saw your chiropractor. And well, we both owe him a great debt of gratitude for
You're right.
getting things taken care of.
You're right.
And interesting that, you know, despite the fact that you were a patient of mine, I was not aware of your temporomandibular disorder until you brought it to my attention.
I was gonna say, I don't think I ever mentioned it to you, because I just
Yeah.
thought it was one of those things that, you know, that happened. And then, like I say, when my speech started going, and I was scared after a stroke.
Yeah. So it affected your tongue. Evidently, the numbness affected your tongue, and to the place where I think you said there were times you didn't want to go to work because of.
Like I had, almost like I had a speech impediment, you know. And it was just like I was cut in half. It was just the left side. The right side has never been bothered. But so it's just always been the left.
Yeah. Interesting. Well, shows we got a lot more to learn before we get done with learning about this problem.
Yeah, it's really scary. You know, when I didn't know what I had.
You bet. Yeah. Well, I appreciate your taking the time to share that information.
Ah, good. Well, what do you know? We finally got
something going?
Yep.
Is Joan. We saw Joan a number of years ago. She had had frustrating experiences in diagnosis and treatment. Her primary symptom is a neurologic one. In fact, that is her only symptom. I cannot explain it, and to my knowledge, no one else has been able to come up with a reason why she experiences this symptom. However, with treatment, she is comfortable. She is comfortable so long as she wears an orthosis. Should she take it out, her symptoms return very quickly. An interesting sidelight is that after we did the interview with Joan, we did an MO amalgam on tooth number 3. 5 minutes after I injected that tooth, she took her appliance out and left it out and said she did not and would not have any symptoms. And she confirmed that when the appointment was done. She also indicated that she had numbness down to about the lower right cuspid area and across to her nose, both of which are a little unusual for an infiltration anesthetic in that area. Again, I cannot explain why that is. I can only relate to you what people share with us about their experiences. I'm hopeful that the tapes will provide interesting to you and of some benefit. Should you have further questions about the course or about treating temporomandibular patients, I would be happy to arrange to visit with you. Thank you very much.
I'm Phyllis Stample, and I'm a patient of Dr. Reedhead's. Phyllis Stample, and I started doctoring for TMJ in '87. It started in '86, and it started with a numbness in my face that went up through the whole left side of my head and in my tongue, and I thought I was having a stroke. So So I went to a medical doctor, and they x-rayed my head, and they thought I had a brain tumor, which I didn't buy, and so I was not going to accept the fact. So I went to another doctor and got another opinion, and it just gradually got worse and worse, and they thought, well, maybe it was my migraine headaches. And so I went to Iowa City, and they ran me through all sorts of tests. They finally decided that it wasn't MS, and so I had started going to a chiropractor also for migraine headaches, and he suggested that it could be very possibly be TMJ, and he suggested that I come to Dr. Reedhead, whom I told him was already my doctor. And so Dr. Reedhead started me out with an appliance, and I probably wore that a month, 6 weeks, during the day and in the evenings. And then he gave me a partial, which helps, and when I fail to wear my partial, my jaw starts getting numb, and it goes across my lips and up the left side of my nose and my face. So I have to start wearing my partial again, and it takes the numbness away, and it seems to correct the problem. I went to a medical doctor for a year and a half because when the left side of my face would go numb, it would generate down my entire left side. I never received any medication for it because there wasn't any pain, and sometimes it would get so bad and it would affect my speech because the left part of my tongue would go numb. I guess that's what scared me more than anything, and that's one reason why I had the x-rays, and they told me I had the brain tumor, and then that's when I switched doctors, and they sent me to Iowa City for all the tests.
Our next patient is Phyllis. Phyllis has been a patient of mine for a number of years, and it's interesting that although people develop symptoms of temporomandibular disorder, they don't always know that you might be able to treat that problem. I think her narrative indicates the importance of letting our patients know that we do treat temporomandibular disorders, and that we are able to help them. A couple of things that I would correct about Phyllis's interview is that Phyllis wore her appliance for about 3 months before we constructed a removable partial denture. At that time, she'd been asymptomatic for approximately 2 months, and we knew that lack of posterior support played a significant role in her situation. Phyllis is a periodontal patient who had chosen to not treat her periodontal disease for a number of years. When she began to lose teeth, she chose to actively pursue treatment. She is missing all of her molars on the upper right-hand side. She is missing her second bicuspid and second molar on the left-hand side. She has a full complement of lower teeth. Lack of posterior support plays a very significant role in the development of craniomandibular disorders, and it can be a rather insidious development of symptoms. Phyllis found out that after she was better, that going without her partial was not an acceptable approach for her. She came back about a year after we had constructed the partial denture, complaining of symptoms again. And in interviewing her, we discovered that she was leaving her partial out a great deal of the time and actually wearing it only to eat. People forget their symptoms very quickly, as I have been reminded by a number of patients. And that's why it's important to document what goes on with them. Phyllis is a very nervous type of person. She would be characterized as the kind of female who would have migraine type of headaches and could easily be written off as a complainer. Her migraine headaches are not a result of true migraine, and they have not reoccurred since she has had adequate posterior support. It is important when someone talks about migraine headaches to ascertain whether or not they have migraine headaches in terms of the intensity and the type of pain that they experience, or if they have true migraine headaches with prodromal syndromes and true photophobia. Many people have been labeled as having migraine headaches who truly do not have migraine headaches. Treating temporomandibular disorder patients restoratively requires that we pay great attention to detail. I'm reminded of that in two instances. The first being that of my wife. I treated her for a number of years when I first began to treat temporomandibular patients. And she would attest to the lengthiness of that treatment. She wore lower appliances and she wore upper appliances and had orthodontic treatment and a variety of things, some of which made her worse and some of which made her better. But we finally got her to the place where she was almost comfortable. And at that point in time, because of her frustration and mine, we decided to proceed with significant restorative therapy involving 10 crowns, which she really needed. When all of that was completed, she was still not comfortable, and we struggled with trying to accomplish that by changing the occlusion, doing some adjusting on the porcelain. To make the story short, one of her upper cuspids was left slightly out of contact on lateral movement as a result of her orthodontic therapy. And she became comfortable and has remained comfortable when I added a little bit of lingual composite to that tooth so that she had anterior guidance immediately upon making a lateral movement. That is a small detail that one can frequently overlook. I was recently reminded of that situation again when I constructed a 3-unit anterior bridge and a porcelain facing for a temporomandibular disorder patient for whom we'd done posterior reconstruction. And this lady has been comfortable for several years, but she wanted the bridge redone because it was 2 3/4 crowns holding that bridge in place. Unfortunately, when the work was done, the anterior guidance on the cuspid was not as steep as the guidance on the bicuspid and the molars. And this allowed her to redevelop a working interference on the upper right side. She came back in about 6 weeks later complaining of some reoccurrence of some symptoms, some clicking in the left joint, and when we looked at her situation, I discovered that we did not have adequate anterior guidance. It looked very good and it was very close, and I did not check the anterior guidance when we submitted the bridge work. Consequently, we had to do some minor equilibrating and add a little composite to the facial of the lower cuspid to help that situation, and she's now comfortable. But we must pay attention to all those details as we do the restorative work for these patients. it's easy to forget that they are a little different from other patients and cannot really tolerate some of the occlusal interferences that our regular patients can put up with. I've taken numerous courses over the past 10 years with a variety of clinicians dealing with temporomandibular disorders. One of the frustrations is that in the beginning you hear a great deal of information and you can hear a lot of different opinions about how to treat temporomandibular disorders. My reaction is that it is so complex for many people that they choose not to become involved in it. You would also tend to believe that you have to do an assessment on patients that is quite extensive, involving muscle palpation and a number of numerous measurements and documentation, so that you have all the critical information. I think we tend to get overloaded with data about temporomandibular patients. My own experience is that 80% of the time I can interpret a written history of the patient's symptoms and determine whether or not they are a candidate for treatment without ever having talked to the patient, without ever having conducted a clinical examination. There are several major lecturers that have spoken to that issue also, and I believe that that is correct. I don't think it's necessary that we spend 2 hours interviewing the patient and going through a battery of tests, and that they be analyzed by a psychologist and a physical therapist.
Let me film the gold. Let me film.
I don't want
I know
you had
help me. You can hold the bag.
you had all day
Come on!
cut worms. You know what?
You can hold the bag.
That's sad. I have to call David. Nope. Get in here and eat your fruit and put that down.
Why?
Now. Hello, and thank you for joining me. I'm Paul Reedhead. I practice general dentistry in Ames, Iowa. For the last 12 years, I've had a great interest in the treatment of temporomandibular disorders. It initially started with a trip to the Pankey Institute, and since that time I have taken courses with a number of clinicians and read a majority of the literature that has been available on the treatment of temporomandibular disorders. One of the frustrations for me initially was particularly emphasized in reading Dr. Gelb's book. And in that book, every clinician that spoke indicated that it was important to use his particular technique in treating temporomandibular patients, and that without using the skills of that particular specialty, that it was unlikely that people could be helped. It was frustrating because it's not possible in Ames, Iowa to gather around you a multidisciplinary staff of people to treat the complexities of temporomandibular disorders. Fortunately, I persevered, and what I have discovered is that by and large dentists can handle the majority of temporomandibular disorders without a great amount of sophistication in terms of auxiliary personnel and auxiliary types of treatments. On the tape, you will meet two women. The first one is Joan. There are several things that I think are important to understand in listening to her interview. I think the first thing is the importance of a good history. When I initially interviewed Joan, I knew that I could help her by the information that she gave me in the history. You might see what information she gives that reveal that. Another thing that became evident was that she would be a candidate for either surgical intervention because she had a class 3 skeletal relationship, or she would need some kind of fixed stabilization, some kind of long-term stabilization. Because of her concern for maintaining comfort after it was once established, she chose a removable cast metal splint. That splint has functioned very well for her for 14 months. Although she is experiencing a little pain in the left joint episodically now, it is not at a point where she would choose to do. Another thing that is evident is that it does not require a major teaching institution to render competent care. Both patients have been evaluated at some rather prestigious institutions where we have quality people. But sometimes that can be a disadvantage. I think the most important thing that we have to know is to listen to the patient, to listen to what they have to tell us about their situation. Because if we listen, people will tell us what we need to know. There's an old adage: it is not so important to know what kind of disease the patient has as to know what kind of patient has the disease. I think in the treatment of temporomandibular disorders, that is a very true statement. And it also emphasizes our need to be attentive listeners to these people in pain. is a person who is involved in the care of others. She is a registered nurse and understands healthcare needs. Her story exemplifies the frustration that people can experience when seeking a solution to their problem. Joan is very protective of the fact that she is now comfortable. She has experienced pain for a number of years and truly does not want to re-experience it. I can appreciate that for her. And as a result, we chose to use, I think, the treatment that was most appropriate for her situation. Phyllis also exemplifies the fact that a solo practitioner can solve a rather complex problem for a patient. And while these people are not typical, they are not so unusual that when you treat temporomandibular disorders, you will not encounter them. Very recently, I had a patient that we evaluated for temporomandibular disorder about 6 months ago. And because of cost, the person chose not to proceed with treatment. She came in later with a tooth that was uncomfortable, and I assessed it. And my conclusion was that endodontic therapy should be done on that tooth. I did the root canal, and she still had the pain. Unlike in Joan's situation, we did not extract the tooth, but at that point I made her an occlusal orthosis. She now is comfortable, and we both know that while there may have been some endodontic involvement in that tooth, probably the majority of her pain was from temporomandibular disorder. None of us get too smart to know all the answers. And so it is a struggle and an endeavor to treat temporomandibular disorder patients. I hope you enjoy the conversations with these two ladies. It was fun to treat them. I will continue to enjoy doing that kind of work, and would encourage you, if your interests take you there, to pursue that kind of endeavor. It's truly rewarding. One of the other important points that we can gain from Joan's interview is the fact that appliances are different. And not all people know how to make appliances that are effective. There is a big difference. Joan had a number of appliances made. Most of them helped her to some extent. Some of them were very inconvenient, and some of them didn't help at all. And other people who assessed her felt that appliances would not be helpful for her. The appliance design that we would teach you is the one we used for Joan. I found it to be highly effective. It can meet all the criteria that an appliance should meet, be that the criteria of the Tanner appliance or the Shore appliance. Those criteria can be met, and you have to decide how much of the criteria that you want to meet. Stable occlusal stops should be provided, and interior guidance is a must. Stability of the teeth needs to be ensured. But how we do that can be different for different people. My point is this: if you're going to do appliance therapy, you need to learn how to do it sits in the fossa in a medial-lateral relationship. Is it skewered to the medial? Is it skewered to the lateral? And what is the relationship of the corresponding joint? So we are really limited in our ability to look at and analyze the temporomandibular relationship. And any radiographic analysis that we do is significantly flawed. It is my feeling that most of those radiographs are of little value, with the exception of allowing us to look for tumors, osteoarthritic changes, and gross mount relationships. What we're really wanting to do in normalizing craniomandibular relationship is to allow the condyle to seek the best physiologic relationship that it can relative to the fossa. And that must happen in both the left joint and the right joint. Given the fact that there may be some disharmony, we may not establish an ideal relationship. The best way, in my view, to do that is to minimize dental proprioception. We have to take the teeth out of contact, and we do that with an occlusal orthosis. Prior to doing that, equilibration really has no place in establishing a proper occlusion. I have used maxillary appliances. I've used mandibular appliances. I have used the Shore appliance, which is I have used the Shore appliance, which is a maxillary appliance. I've used a variety of mandibular appliances. I first learned to use a Tanner appliance. I later learned to use a Sears appliance. The Sears appliance is very similar to the appliance that Dr. Gelb uses, with some significant differences. The purpose of the appliance being to stabilize or optimize the craniomandibular relationship, we need to allow that to happen by separating the teeth. The best way to separate the teeth is to allow just one tooth on each side to hit. This maximizes the possibilities of allowing the mandible to shift into a more normal relationship. However, we need to understand that allowing teeth to hit in only one spot also creates an unstable relationship on an ongoing basis. Therefore, we use the appliance for about 2 weeks with contact on one tooth on each side of the arch. Generally, in that time period, pain goes away. If it does not, we might choose to extend for another week. That is the maximum length of time that I would choose to allow anyone to wear a pivotal type of appliance. If the jaw is not shifted in that 3-week period, it is not going to shift with more time. At that point, we stabilize the jaw position by relining the appliance to a full occlusal appliance. We do that by springing some plastic on the occlusal surface of the appliance and having the patient close into the appliance until they contact the appliance in the same way that they were doing when they came in. When the acrylic is set up, we trim it down until we have a flat appliance in the back with cuspid guidance. Personally, I do not reline the anterior of the appliance to bring acrylic into contact with the lingual surfaces of the lower anterior teeth. In using that appliance design, I have had teeth shift only about 3 times in 6 years. I do not see it as a problem. If you are uncomfortable with that approach, you certainly may reline the linguals of the lower anteriors. You may even bring the acrylic over the incisal edge. I have found that that is more cumbersome for patients and typically does not serve a very useful purpose. However, I understand that that is not a generally accepted routine, and I would suggest to you that if you are uncomfortable doing that, that you would certainly choose to cover the linguals of the lower anteriors. It is a good idea. 90% of the people that you see will be comfortable or almost comfortable at the end of the 2-week period. We continue to see the patient on a weekly basis and adjust the spots on their appliance so that they're even. Generally, after about 6 appointments, there's very little movement of the mandible. And at this point, we can assume that the mandible has assumed the most physiologically normal relationship that it can with the maxilla and in the fossa. That certainly does not mean that everything is ideal, but I think it means that we have achieved the most normal position that we can given the circumstances. As a general rule, this does not eliminate clicking joints. For a number of years, I used anterior repositioning appliances. It has been my experience that while we can eliminate joint noises for a period of time by using an anterior repositioning appliance, that those situations generally do relapse and redevelop noisy joints. I'm not comfortable with translating the mandible significantly forward and restoring that person to the, I believe Gelb calls it the 1-5 position, or down the slope of the fossa. The reason that I feel that's not necessary is that we certainly see a number of patients functioning with clicking and noisy joints over a lifetime with a minimum amount of problem. I believe that our temporomandibular disorder patients can be allowed to function similarly if all the other structures are normal. You have to decide how you feel about that issue and make that decision for yourself. The understanding that we have a condyle-fossa relationship that is not normal, and our attempt to normalize that is really the foundation of how I treat patients. Learning to use an appliance well will allow you to make a majority of the patients that you see comfortable. Once they're comfortable for an acceptable period of time, and I consider that 3 to 4 months, they can be restored or rebuilt or whatever you would choose to do at your convenience and theirs. Treating temporomandibular patients can certainly be a very frustrating experience. It is also very challenging and rewarding. I certainly have experienced what I would consider more than my share of frustrations over the 12 years that I have seen temporomandibular disorder patients. And there have been several times when I felt like it wasn't worth it and I would quit. I'm certainly glad that I did not. One of things that has been truly rewarding about my years in practice has been the ability to help people with this kind of problem. I look forward to continuing to help people in that area in the future. I also look forward to helping dentists be able to solve that problem for their patients. I wish you luck, and I wish you education.